It's a pleasure to present some work of ours here and have some shared thoughts on psychiatric vulnerability and how this relates to COVID, etc. I'll try to share my screen. And if that won't work, we always have backups. So let's see. Is this visible for you guys? Okay.
Er gebeurt nog niks. Nothing happens.
Bas, can you take this over? Present from your place.
Yes.
Then I'll just ask you to go through the slides.
Yes, we'll share it.
And then we'll do it that way. Now, first of all, I made this joke about 2 years ago when we had a nice symposium here, where Professor Hebrand also presented, and I made the joke that that the language of science is, of course, English, but let us be fortunate that it's not Latin as it used to be. Then it would be really complicated for me and for most of you, although I expect that some of you have spoken some word of Latin during their careers, but let's be happy that we can do it in English and not in Latin. So yes, you can open the first slide, Bas, if you're willing to help me out of here. So what I like to do is to present a sort of broader overview about the need for prevention and about psychiatric vulnerability and resilience and how this in a more broader perspective relates to some COVID problems. And this is a sort of broader umbrella that will be picked up by Professor Hebrand to go in more depth of, let's say, the clinical diagnostic aspects of this psychiatric vulnerability and how it relates to the COVID pandemic. Next slide, please.
Can you still see the presentation?
No, I can't, but...
Sorry. Something went wrong. Now?
Yes, it's quite visible now, and it's good. We can go to the next slide. Yeah. So I would like to go through, first of all, I'd like to show you a sort of extreme example of long-term prevention efforts that have been made in the past. Then explain the concept of psychiatric vulnerability. It would be helpful if you can put your microphone out. Thanks. So, and the presentation back again. So I don't see my presentation yet.
Facing some technical issues. We will have to solve it in a second, sorry.
Okay, don't worry. Part of my talk is about resilience. So how to deal with adverse circumstances, and I think you will be fine and make it. Oh, Johannes, your mic is off, but I see that you're still talking.
Yeah, maybe it's because you're not speaking Latin.
Yeah, that's true. Marcus et Cornelia in hortus ambulant. Subito Marcus exclamat. Marcus Cornelis, serpentem in hortus fidemus. Well, let's quit there. That was some easy Latin for some of you.
Ich wollte gerade Amen sagen.
We are just waiting for Bas to connect so he can share the presentation, because apparently we are facing some issues. but it should be only a few more seconds. So we'll continue in a few seconds.
That's okay. What you will be seeing, because I'll go quickly to the content later on, but then I will go to one of the first examples of long-term prevention, which is I think is relevant, and it's a sort of a serious joke about how you should organize that, and it has some key elements that are of relevance, I think. And then I will go to some thoughts about psychiatric vulnerability. What do we actually mean by that? And are the systems, as we have these in the Netherlands and Germany, do they really account in the right way to deal with what psychiatric vulnerability actually is? And then I will continue what the effects are of COVID on this vulnerability and how it will develop psychopathology in some cases. And after that, I will probably finish and pass over to Johannes Hebebrand. So that's more or less what I will do. So I'm trying to buy a little bit of time in my introduction part. We can actually go to the next slide. Yeah. Okay, make that one large, or is it largely visible? So what you can probably see are some pictures of the Netherlands and some parts of Germany. On the left, you see how this was during the time of the Romans. Then you'll see the 16th century and the current situation. And the guess what is, of course, if we don't... I need to let Bas in. Of course, there's the situation in guess what if we wouldn't have water protection in the Netherlands, which includes, for instance, dikes, but also all other sorts of facilities. And kind of nerdy, I looked up at how many documented disasters of flooding have been occurred in the past, and there were over 60 descriptions since the year 1000 about floodings. So next slide, please. And these, of course, have a dramatic effect on the population. What people, of course, did is try to solve this issue. And this trying to prevent flooding is, of course, an extreme example of prevention. Next slide, please. One further. You can go one slide ahead. Yes, this one. This is the one I need. So I went through this 2 nights ago, somewhere in 3 o'clock in the morning, but I was quite fascinated by all these floodings. So I tried to put them in a sort of graph. And what you see on this graph is on the x-axis is, of course, the year you live in. And on the other, the y-axis is the number of deaths that have occurred. Now, these are not all the floodings. These are all the floodings that have been documented with death rates. And what you can actually see is a quite broad spread, but as you also can see, fortunately, is that the number of deaths decreases during time. And this has to do with the improvement of prevention. The prevention got better and better and better. So people organized themselves better, collaborated, and made several good arrangements to make this prevention work. Next slide, please. And this ended in the famous Delta plan in the Netherlands with all the water protections. But I want you to focus and remember the principles. They are relevant. So the principles that people thought about this Delta norm of protection is that you have to protect major areas of flooding. You have to identify them. What are the vulnerable places? And the second one is that you have to assess the costs of flooding in a statistical model. So know how much damage you have, how much loss of production, lives, etc., etc. So objectify the effects of flooding. And there's a quite dramatic statistic that says that the human life is worth $2.2 million in that design. Of course, there's also a need to constantly be aware of changes in the type of water floodings, and you need to keep a good look at the scientific knowledge about flooding. And this is all part of this delta norm. So next slide, please. And I thought this helps principles for how we should organize healthcare. So one of the things is if you would compare major areas that you need to protect from flooding, that would be the same in psychiatry to say which people are more vulnerable and should have more protection. With respect to costs of flooding, there are statistical models. We don't have, of course, the models of the waterworks, etc., but we have, for instance, business plans, and some work is available that shows how much costs are related to prevention and how much money does that bring in. I made this dramatic conclusion that if a life is worth in the Delta plan $2.2 million, then just alone the suicides that occurred in the Netherlands in 2019 would already be a cost factor of 150 million euros. Now, the same goes for to know how things change and to know how, what data are available about flooding. They relate, of course, to the work of knowledge institutes. It's one of the reasons why we are working together with our German counterparts, because we think it's very valuable to share knowledge and to learn from each other. Next slide, please. And that should bring me to, well, this we can skip this one. Next slide. This is quite obvious. If you think about psychiatric vulnerability, you must understand it is subjective. It involves cognitive, emotional, and societal aspects, but of course there's no clear definition. Next slide, please. So, for instance, just to give you a sort of flavor to what I mean with psychiatric vulnerability, I, of course, put a picture in there of Nelson Mandela, who had been in prison for more than 20 years in a cell of less than 5 square meters, working in the mines at Robben Island. He had to wash himself in seawater. He had no eye protection in these regions and actually had some eye problems due to that. But remarkably, he didn't develop any major psychiatric disorder. This is, of course, not something you choose for, but it's an example of limited vulnerability. On the other end of the spectrum, there may be a group who is highly vulnerable and in certain circumstances will develop psychopathology. So the point here is psychiatric vulnerability is highly variable. So next slide, please. And if you look at this, and this is work, I could put in a reference, I didn't do that, but it's work from Caspi and Moffitt, who are two famous researchers, is that there is a lot of data that shows that this vulnerability to develop a psychiatric disorder distributes like a sort of Gauss curve or a continuous curve. And this bell-shaped curve actually means that most of us have a sort of average vulnerability to develop a disorder, and a much smaller portion has a really high risk to develop the disorder. And it's, of course, this group of high-risk children that we see in our psychiatric units in the end. But it's important to note that for the most of us, this psychiatric vulnerability is rather average, and much related to environmental circumstances. Next slide, please. So this just to explain a little bit how such a Gaussian curve works. So most of us are in the middle, same as others. And then you have, of course, the group that's more to the right and to the left, etc. And on the x-axis, you can see, of course, the percentage that it includes. But most of us are within this, between this probably more than others, probably less than others, which is the largest range, and it's about 95% of the whole curve. Next slide, please. Now, it's important to recognize how vulnerable you are early during development. And this has a really simple, basic reason. And the reason is that the ability of the brain to change and to deal with circumstances becomes less and less and less during time. So I myself am now 52 years old, so I'm quite poor in adapting to changing circumstances. So my possibilities that my brain will adapt to radical changes is really difficult. For instance, if we were forced to speak Latin, all of a sudden it would be really a hard exercise. It's a long time ago, my language skills decreased during time, and there's a window of opportunity for learning, so it's more difficult. So if you are vulnerable and you can identify that early, you probably can change things a little bit for good before you are already fixed and not changeable anymore. Next slide, please. Now, to give you some flavor, I think the children with this high P factor, this high psychiatric vulnerability, includes people that, for instance, have a specific genetic syndrome, have often several somatic problems. We know that the kids that we see that are really highly vulnerable often have somatic complaints, and in a range of about 60%. Multidisciplinary approaches are needed, and usually this requires a sort of lifetime perspective for this smaller group. For the average P factor group, which includes most of us, there's a strong interaction between genetics and environment. And it's much more episodic that you will develop psychiatric problems. And there the importance of primary prevention really comes large, and is something to work out a little bit more further. So next slide, please. Now, I do want to emphasize, because we have a really broad audience, that there is always some confusion between classifications, such as is used in the DSM or the ICD, and clinical diagnosis. And I try to explain this by showing that classification would be that you can look up what type of plant you are looking at. So we call this a flora in the Netherlands. So you can look it up and check it, and there are criteria, and you end up with some name of some plant. Diagnosis would much more be what is needed for this plant to grow well, how much water does it need, how much light does it need, what are the circumstances that promote growth, and what are circumstances that limit growth. That is the whole range of clinical diagnosis, and classification is just part of diagnosis, but there's often a confusion there. Next slide, please. Now, one of the main problems that relate to psychiatric vulnerability is that the current systems are based on a dichotomy. You have a disorder or you don't have a disorder. But because this vulnerability is sort of continuous, the systems do not always work well. And maybe a different organization is needed. Furthermore, these systems hinder the concepts of ampliation and prevention. So ampliation is, for instance, promoting well care, even if there are no disorders yet. Next slide, please. So one of the basic outlines I thought about, if you look at this curve, is that if you have a sort of average vulnerability, then normalization is an important factor. It is important that for the larger part of our population, we normalize. So looking at children who now come back to school after a lockdown due to COVID, it's important to express that they are not a sort of lost generation who has a terrible disadvantages. It's important that you explain that they have opportunities, that they went through a crisis where they can learn things from. So that is a form of normalization. And it's important because the highly vulnerable group will need our care, and not the ones who don't need it. So that's important. And that brings the the perspective of triage into place. So which person needs what type of care, and we should put an effort in promoting triage early in trajectories of clinical care. Only after that you come into the domains of clinical diagnosis. So you see that this vulnerability increases, and then you come finally to treatment. And for the really highly vulnerable group, which is the smallest part, of course, of this curve, long-term care is needed, and probably the most cost-effective if you arrange that well. So next slide, please. Now, there are some interesting reactions that you can see due to the COVID pandemic, which relates to psychiatric vulnerability. We know if you put pressure on a population that you usually see three types of reactions, which can mix, but it's internalizing, externalizing, and psychotic reactions. And internalizing is, for instance, that we all blame ourselves, that our society is not well developed, that we have much too much international traffic, etc., etc. And externalizing is, for instance, that we do not agree with the measurements that need to be taken, and we are angry. And of course, you have these psychotic reactions that people think that in their vaccine, Bill Gates put a chip or something like that, which is really a strange thought. And it's really important that if you reflect on that from my discipline, it's not really useful to go and have broad discussions with these people who believe that, because it will not be correctable. But these are the reactions at the population level. So next slide. We can see the individual reactions, which of course are familiar. Now, one thing that is important to note is that what we see in our data is that internalizing problems are much more prevalent now during the COVID crisis. And especially the three I mentioned here. So eating disorders, depression and anxiety disorders really raise to high numbers. I can't show you all the details because the publication is still under review. But this is what I can tell you. We know that this happens. Next slide, please. And I want to raise the alarm for the steep slope of the curve. Next slide, please. So the alarm is this one. If you put pressure on this distribution, this normal distribution of vulnerability, and this pressure is high, then this small group, which is totally on the right, there will be more psychiatric disorders going a little bit towards the middle of the distribution, and you will get to this steep slope, and then you can expect rapid rising of numbers of people with psychiatric problems. So this pressure of COVID, if it lasts too long, will put the pressure too high, and people who are in this a little bit of risk, not as high as the highest vulnerable group, will also come into the picture, and then numbers will rise rapidly. What we of course hope is that if this COVID pandemic will pass, that these numbers will also decrease rapidly again. But we are not sure. So this is one of the things that we are worried about as field of child psychiatry. Next slide, please. This is just a short statement about the importance of ampliation prevention and treatment. And there are some basic interventions that overlap. So whether you call it prevention, ampliation, or treatment, there are overlapping principles. And I would like to address how schools could relate to that. So next slide, please. So for instance, what we know is that green environment is helpful for children. And unfortunately, in the Netherlands, for instance, most schools have this type of environment, which is not really green, but basically, how do you call it? A sort of stone desert. It has been mentioned. It's also important that you have sufficient movement. But what we see is that in our classrooms, we usually sit down, and we're supposed to sit down all the time. The brain usually works better when you move. So some of you will actually notice if they have to learn something by heart or had to do that during their studies, that you start walking around and trying to memorize things while you are walking, because the brain works better when you move, for most of us. And of course, small groups work better than large groups. So one of the prevention measures could be make the classes a bit smaller, make the number of children in one classroom smaller. Of course, then you come to another problem, that you don't probably have enough teachers to do that. But that should be a problem to tackle. Next slide, please. Something about resilience. There's a whole sentence here, you can read it. But the main point is that resilience, veerkracht in Dutch, is a learning process. That is what I like to emphasize. It's something you learn. It's not that you are just born and, oh, you are resilient. You need life experiences and feedback, and that will build resilience. And there's a really nice papers in Frontiers of Psychiatry that you all should read. It's quite readable. It's not really technical, but it has basic principles of resilience well described. So please read this, for instance, in the evening. If you're really fed up with work, then this is really good. Next slide, please. And there are some basic principles I like to light out. It is a learning process, again. One of the things is that if you're faced with adversity, learn to broaden your scope of opportunities. So what went quite well, at least I know for sure in the Netherlands, is that most teachers did not say, oh, you can't go to school, now you don't have school anymore. No, we used, for instance, Teams or Zoom or whatever to teach our children, which is a form of resilience. It's also important that you make inner sources explicit. Some people don't know that they have certain skills that will be helpful. And if children go back to school, the first thing we should say is, how did you make it? How is it possible that you sit here again in the classroom and you look healthy? How did you do that? How did you accomplish that? It's really good. Another important issue is that in acute moments of crisis, don't overreact emotionally. That's one of the mistakes that's often made. And of course, work actively on positive social relationships. And for youngsters, this is really important. So during the lockdown, one of the problems is that the social networks, really diminished a lot for all of us, but especially for our children and youth. Next slide, please. Yes. By the way, this picture is a form of resilience. It's a city on the water. And it's a kind of blinking the eye to my initial slides in the beginning. But this is one of the ideas engineers come up with this city. It can actually open up and close down depending on the weather circumstances. But it's really interesting. So I hope you enjoyed. And let's take some questions, if there are any.
Dankjewel, thank you very much. Herzlichen Dank, Wouter, für diesen sehr interessanten Beitrag. Zijn er vragen via de chat binnengekomen? Vraag ik even aan onze regiecentrale.
There are no questions in the chat so far.
No questions. Oké. Ik heb zelf wel een vraag. Misschien dat er straks nog wel een vraag uit de groep komt. Kan ook altijd. Ik denk dat heel mooi duidelijk gemaakt is de lijn van waar hebben we het over? Kwetsbaarheid. We hebben het over COVID gehad. We hebben het gehad over de weg terug. Normalisatie. Problemen die daarbij op kunnen treden. Voor jeugd, voor kinderen. En ook veerkracht aan het eind. Van hoe gaan we daar nou mee om? En hoe kunnen we veerkracht vergroten zodat er minder problemen ontstaan? Dus ook preventie. Mijn vraag is, omdat er nogal wat vertegenwoordigers ook van gemeenten hier meeluisteren vandaag. En gemeenten zijn verantwoordelijk voor jeugdzorg. Daar komen ze in eerste instantie binnen. Wat zou nou een gemeente kunnen doen? Hoe zouden ze effectiever in kunnen spelen? Initiatieven nemen op het gebied van preventie, zodat die curve niet steiler wordt. Want dat heb ik wel begrepen. Die curve mag niet steiler worden, want dan hebben we direct een heel groot probleem. Ich kann die Frage auch nochmal auf Deutsch wiederholen. Die Kommunen sind da sehr stark in der Verantwortung, wenn es geht um Jugendpsychiatrie. Und was könnten die da tun, um dafür zu sorgen, dass die Prävention besser funktioniert, damit nicht noch mehr, auch durch Covid, noch mehr Jugendliche in die Probleme geraten, um das zu vermeiden?
Thank you for this excellent question, which is spot on, as they say. It relates to the slide I showed, how you should organize your care systems. And if you talk about normalization, you talk about the larger group, which has a sort of intermediate vulnerability, but not the largest. You want this group not to move towards psychiatric disorders due to circumstances. And with respect to COVID, of course, all of us need to be vaccinated, including IDUs. That is a no-brainer for me, but it's just more the medical part. And it's not what you mean, but I still like to emphasize on that. Please, please, please vaccine all the people you can. It's the only way out. But what you could do at schools, for instance, is one of the large environments, of course, of youth. So the interaction between care systems and schools should be promoted. Mm-hmm. But of course, if you do that, you need professionals from the healthcare systems who are able to perform forms of triage. Not necessarily always say this kid has problems and a disorder. So you need professionals who have skills in psychiatric disorders, but are also capable to say this is not the field of psychiatry. Perhaps social interventions are needed. For instance, if there are people who have children who are in a family where economic issues are really problematic, you should tackle the economic issues. And you cannot solve that problem through psychiatry, for instance. If you don't do that, then of course the children who do need our psychiatric care and who are highly vulnerable, we cannot help all the children. That's the difficulty. That's one of them. The other one is that you must think about, I think, for this broader population, to look at really lifestyle. And lifestyle includes programs that relate to what is the healthy movement, what is the healthy diet, etc., etc. And we have a world to win, because, and it's not just the gemeente who can solve that, of course, but they can help to raise these issues. It's a societal problem. It's surprising that if you go to in a supermarket, that unhealthy products can still be sold as being really healthy. And you have to put a lot of effort in detecting which product is actually healthy. The same goes for how we arrange our schools. And I already said, if you would limit the number of children in a class, that would be of great help. But to do that, in order to do that, school must have more teachers. And one of the things that we see in our programs in the Netherlands is that there goes money to the schools to work on COVID problems, but actually you need more teachers. So, and if you don't do that, it's really difficult to solve all these problems. So there are a lot of things to say about this.
Mm-hmm. Okay, dank
But I
je.
see some raised hands.
Ja, ik zie ook een hand. Zina?
There has been a question in the chat.
Okay.
De heer André Postgens vraagt, als u het heeft over normaliseren, hoe denkt u over de inzet van praktijkondersteuners bij de huisarts, jeugd?
Ja, ik doe zelf consultatie bij huisartsen. So I do some consultation at the general practitioners in the Netherlands. Wat heel belangrijk, dat is buitengewoon effectief, laat ik dat eerst zeggen. Dus wij zien tientallen procenten reductie naar de tweede en derde lijn in die praktijken. Maar het is heel belangrijk dat je dan wel ook de normaliserende insteek kiest. So you have to have the capacity to look with normalizing glasses. And not all professionals are trained to do that. So one of the things we need to do is provide training how to normalize. And within Character, and I see Joshua, you are actually in this call. Joshua worked on a program to train professionals how to normalize. Because if you don't train it, it's really difficult to do that. But that would be one of the key factors.
Oké.
Er is nog een vraag. Er is nog een vraag door Lianne Baltussen. Geld. Niet naar scholen, maar naar leerkrachten. Geld is tijdelijk. Aannemen van de docenten is een structurele uitgave voor scholen.
Ja.
Opmerking.
Ja, dit relateert aan mijn knipoog naar de delta werken. Dus als je echt iets wil bereiken, kun je wel, even om die analogie te gebruiken. Stel je zegt van ik heb nu eenmaal zoveel geld en die dijk wordt 1,5 meter, maar je hebt 3 meter nodig. Dan kun je net zo goed niet bouwen. Dus ik denk dat je met z'n allen samen toch moet optrekken en zeggen je zult fundamenteel structureel een aantal dingen op orde moeten hebben.
Oké.
En als kun je als gemeente natuurlijk ook niet zo heel veel.
Ja, dat spreekt natuurlijk ook voor een krachtenbundelend signaal richting
Absoluut.
overheid. Om daar tot structurele oplossingen te komen. En dat is denk ik aan de Nederlandse kant in het informatieproces misschien wel heel goed als gemeenten daar ook samen optrekken. Ik wil het hier voor dit moment even bij laten. Wouter, heel hartelijk bedankt. Ik zie nog één vraag binnenkomen. Is het ook een zaak van zo min mogelijk medicinaliseren? Zie ik hier binnenkomen.
Ja. Ik ben zelf een beetje tegen die term medicaliseren, omdat een medisch perspectief zou eigenlijk heel goed moeten objectiveren of er nou werkelijk sprake is van dysfunctie of niet. Dus ik val het een beetje over die term. En hier wordt meestal mee bedoeld dat je onterecht iemand een diagnose geeft. Ja. En vaak wordt dat ook nog eens een keer gedaan als een klassificatie valt. Dus ik denk dat de crux hem zit, en dat iedereen dat wel voelt in mijn verhaal, dat je iets moet doen aan die grote toestroom. Waarvan je zegt, ja, die kwetsbaarheid is daar helemaal niet mega groot, maar heel erg door omstandigheden bepaald. En we moeten die omstandigheden tackelen. Ja. En voor die hele kwetsbare groep moeten we het gewoon goed regelen. Dat is eigenlijk, en dat hoor ik ook altijd bij gemeentes terug hoor, dat die bereidheid er is.
Ja, ik zie het ook in het tweede deel van de vraag, vooral ook inzetten op sport, gezonde voeding en dergelijke.
Ja.
Oké. Goed. In Anbetracht der Zeit würde ich jetzt diesen Block abschließen wollen. Wir kommen später am Ende auch nochmal zurück mit abschließenden Fragen. Und ich würde jetzt gerne überleiten an Johannes Hebebrand für seinen Vortrag. Lieber Johannes, the floor is yours.
Thank you very much. What I want to do is to point out the consequences of the pandemic as far as we know as of today. I'm pretty sure that if we had the same talk in a year's time, we would know a lot more and would be able to provide much more precise information on what is ongoing and what the results or what the consequences of this pandemic are really for children and adolescents. At the moment, we really do not know whether this is just a wave which will break, or if this is a something longer term, and we are unable to answer this, obviously, due to the short time of the pandemic, despite it being already around us for over a year. So to do this, I would like to see the first slide. Can we go to the next slide? So if we think of what is happening to the lives of children and adolescents, how would the pandemic actually result in more mental disorders or in more mental problems? Obviously, we have very different issues that you can think of. For instance, school closures, online schooling, social distancing, restrictions in social contacts. The fear of infection might be relevant for some children or adolescents. The children and adolescents might become infected themselves, or family members or friends could become infected, again generating fear. We have a lack of recreational activities outside of the home. Many parents are perceiving stress or are in stress. They are maybe economic issues, maybe also working at home, not being able to separate work life from recreation. I've seen that a lot, particularly in better-to-do families, well-off families that parents will essentially work all day online and not realize that they are mixed. They have no clear-cut separation between the time that they spend with their family or with their children and the time that they work. And that potentially there's also more abuse and domestic violence. This list is not complete. There might be more to come. There are more issues around which might have more subtle effects on children and adolescents. But this is an attempt to come up with reasons or mechanisms via which mental disorders might increase. Next. Obviously, before I go into the talk about children and adolescents, we had a survey amongst academic child and adolescent psychiatrists, heads of university hospitals last year. And the major issue was that actually during the pandemic, at least initially, facilities worked to a lesser degree than before. So units were closed. We saw less patients, both inpatients and outpatients. Our communication with families was hampered. The communication between patients and their families, if you're talking about inpatients, for instance, parents could not visit as often or could not enter the hospital at all. So lots of issues related to having less contact between patients and physicians, but also reducing, in case of inpatients, the contacts between patients and their families. Then there's increased workload, stress for employees, risk of burnout. I think a problem that might really be relevant, not today, but in the next few months, because we are already seeing a tremendous increase in referrals. I will go into that in a little bit later. Then there's increased organizational demands. We have to have meetings all the time related to COVID. We have to use novel technology. So a lot of issues to tackle at the same time. Next slide. I just want to point out that our situation here in Essen, and I'm pretty sure it's similar in other departments throughout the region, probably also in the Netherlands, the very same story. So what I did here was take our acute unit, it's a 10-bed unit, small unit, and used for, well, referrals, for instance, due to suicidal ideation, to suicide attempts, who cannot be sent home. They come on an emergency basis mostly. And just look at the column here in red. So it shows that on average, the numbers are rather similar every quarter for 2019, listed as of 2019, first quarter of the year, second quarter, third quarter, going on to 2020 and the first quarter of 2021. And as you can see, starting with the last quarter of 2020, we're experiencing a substantial increase in referrals of emergency cases. So they come with an ambulance. Usually, these are typically children between 10 and 14 years old, mostly coming in for suicidal crises. And the last quarter in 2020, or the first quarter in 2021, you can see the numbers gone up even further. So the increase amounts to 39% in last quarter of 2020 and 67% increase in the first quarter of 2021, indicating that maybe we are really running into severe problems. And today we were just thinking of, if this trend continues, and we think it is continuing in this quarter, do we have to close open wards, open units, to have a second acute unit to accommodate all these patients, which we cannot send home immediately? Next slide. As I briefly told, spoke about, that we had a survey published in the journal European Child and Adolescent Psychiatry, based on the ESCAP Research Academy. I'd like to thank Alexis Revit and Paul Clauser, who did a lot of work on this. And we contacted all the Child and Adolescent Psychiatric University Services by mail and asked them about their, raised several questions related to the pandemic. And as I said in the beginning, the first survey was conducted between March and April 2020. So a substantial reduction, not increase, reduction in the number of both outpatient visits and hospital admissions. The contacted heads of departments stated that the pandemic was having a moderate effect on psychopathology and profound effects on the organization of child and adolescent psychiatric services, with the adoption of new technologies, including telepsychiatry, being a major issue out of many. Next slide. This is the second survey conducted in March and April of this year. As you can see, only we contact 266 heads of such university departments throughout Europe. Unfortunately, only about a quarter responded, and even less filled in the questionnaire completely. We have responses from 22 countries, Germany being the country with the highest number of responses. And there are some countries that did not participate, not a single department participated, unfortunately. Next slide. And I'm just going to go through some of the impressions that these are not hardcore data, but these are the impressions of these heads of the departments. As you can see, the green bars are from the initial point to the beginning, before the start of the pandemic, to June 2020. You can see the impact was perceived as moderate, as I said. But now, in the last survey, you can see that basically most of the child and adolescent psychiatrists report a strong or even extreme impact of the pandemic on mental health of children and adolescents. So that has certainly changed substantially. Next slide. So what disorders or what problems are we seeing more of? And again, the green bars pertain to the period of April, May 2020, and the blue bars pertain to January, February 2021. There's a substantial, I go briefly, 4 disorders or problem behaviors that are have really gone up. Anxiety disorders, the depression, eating disorders, and suicidal crises. As I just showed, and for our own department, the huge increase in large increase in the number of acute referrals due to emergencies is based on this increase in suicidal crises. This is so this is not a problem that just occurs in Essen, but it occurs throughout Europe. And eating disorders for another reason is another interesting aspect, because these are families, usually better off families, well-to-do families. These are not people who are socially disadvantaged. And you can see that this has a very rapid onset effect, and anorexia nervosa has really exploded over the past couple of months. Next slide. And now, in contrast to the previous period, people or the respondents to this survey now indeed report that the pandemic is having an influence on the psychopathology. So these could be anxiety, or there could be anxiety or obsessions, or well, different issues related to the pandemic in itself. So having an impact on the psychopathology that these children present with. Next slide. What are the greatest determinants of this impact? Again, soft data, not hardcore data. And it differs between the younger and older children. As you can see, for instance, closure of schools is similar for both age groups, but there are substantial differences between, for instance, for assembly restrictions being much more of a problem for the older age group, and vice versa, or similar societal stress also being a much greater problem, perceived as a greater problem for the older age group, whereas parental stress is perceived as being a greater problem for the younger kids. So having shown these data, I would now switch to a German study. Next slide, please. This was also published in European Child and Adolescent Psychiatry recently. It's a nationwide German study conducted between, so you can see it's rather old already in terms of the pandemic, May and June 2020. At that time, Germany was in partial lockdown, schools, leisure facilities, and most stores closed. 3,500 families were asked to participate, age range 7 to 17 years. 50%, less than 50% participation rate, and the final sample, as you can see, about 1,500 families. The data were self-reported as of age 11, and parents reported on children younger than that. The authors were fortunate in that they had conducted a very similar survey back in 2017, which they use as a reference base. Obviously, this is not optimal, and might have there might be a bias in there. The data might not really be comparable, but nevertheless, I'd like to go through the results that this group of authors came up with. Next slide, please. So they report a substantial lowering of health-related quality of life in these children. As you can see, for boys, during the pandemic, there's a threefold increase, or almost 3.5-fold increase in low rates of health-related quality of life. In girls, there's a doubling, and this indicates that indeed, seemingly, the health-related quality of life has worsened during the pandemic. Again, you have to be somewhat critical due to the different. These are not the same families that were interviewed, but these are the cross-sectional surveys which were conducted in 2018 and in 2020, and this is a methodological limitation that needs to be taken into account. Next slide. You can see that these are high numbers, so 70.7% reported being burdened by the pandemic. Almost 65% found homeschooling more difficult than before. 83% less social contacts, 40% impaired relationship with friends, 27.6% more arguments in the family, and 32% of the parents reported that disputes escalated more often. So these are, I think, serious issues that could potentially entail greater rates of psychopathology or greater rates of mental disorders. Next slide. And they also use the strengths and difficulties questionnaire to attempt to pinpoint additional effects on mental symptomatology. And they use this borderline cutoff here. Before the pandemic, you can see that mental health problems in total were around, if you combine borderline and abnormal, you add up here about 18% of these children having or more having being either in the borderline or abnormal range. And again, the number increases substantially, has increased substantially during the pandemic, indicating, yes, that it has an impact, and you can then look at emotional symptoms, conduct problems, hyperactivity, or peer problems, and to try and differentiate what the effects are of the pandemic. Obviously, this is one of several studies. I'll go to a second one in a minute. Next slide, please. The slide I just showed you was for boys. This is for girls, and again the same story. You have an increase in the borderline abnormal range due to the pandemic. Again, a clear indication that that the kids or children are seemingly experiencing more mental problems than before the pandemic. Next. Now, this is a somewhat methodologically, I think, better study, just very recently published, termed the Youth in Iceland study. Why better? Because this is a study that is conducted every 2 years in 13 to 18-year-old children in Iceland who attend school. So this is a nationwide survey conducted every 2 years. And these response rates are typically rather high, between 63 and 86% in the years 2016, 2018, and again in 2020. So in 2016 and 2018, teachers distributed paper-based questionnaires to students. And in 2020, the teachers just gave a link to complete the electronic survey to students. In November, this is critical for the interpretation. In November 2020, when the last survey was conducted, there was a strict physical distancing mandate in Iceland, with less than 10 people allowed to gather. And most of the secondary schools had online teaching only, whereas earlier academic levels, including children 16 and younger, continued to receive on-site learning in school. So somewhat less severe implications in Iceland than, for instance, in Germany. Next slide. And again, the same story. They took the symptom checklist 90 to look at depressive symptoms. And as you can see here, there is, in the year 2020, there's a clear-cut increase, higher rate of depressive symptoms. So you can see that the years 2016 and 2018 were close to each other across the age range. And these are girls, these are boys. And that seemingly, if you compare boys with girls, the effects are much stronger in females than in males for depression. But you can also see if you take mental well-being, there's a different scale, obviously here, the Warwick-Edinburgh mental well-being scale. You can see that the children will rank themselves substantially lower in the 2020 survey, and this applies to both, interestingly, both boys and girls. Next slide. Next slide, please. This is just basically the same story. You can look at the amount of children with high depressive symptoms, and you can see a substantial increase in both boys, well, more predominant in girls, but also in boys in the last survey. So a substantial greater proportion of the children would potentially fulfill criteria for depression in the last survey. Next slide. Just to show that there are some other effects that you might view as positive. So, for instance, cigarette smoking dropped substantially, already dropped between 2016 and 2018 in both boys and girls. But look at this substantial drop in 2020. So the pandemic is led to less smoking, less use of e-cigarettes, and less intoxication. So it's not all negative, but basically this, I think, is all due to the fact that there are social restrictions and that adolescents are not in groups as much as they used to be. And if they're not in groups, then they will smoke less and they will also drink less alcohol. Next slide, please. Next slide.
Since we have a bit of a delay, we are already clicked. So.
Okay, so just to come to a final conclusion, I'd like to briefly point out two other aspects that I think you should know about. One is that in some, this is not common, rather rare or infrequent occurrence, the so-called pediatric acute onset neuropsychiatric syndrome. So typically, COVID-19 can be asymptomatic or present with clinical symptoms, which you're all well familiar with, cough, fever, and so on, fatigue, malaise, gastrointestinal disturbances. But there can also be, in children rarely, but nevertheless they occur, neurological and psychiatric disorders. You can see the very serious neurological problems, including stroke, hemorrhages, encephalopathy, and so on, but also anosmia, myalgia, paresthesia, and the so-called Guillain-Barré syndrome. But then you can see there's also this PANS, this post-infectious autoimmune and neuroinflammatory events, and with a sudden onset of OCD, is obsessive compulsive disorder, or a severely restricted food intake and concurrent neuropsychiatric symptoms and motor dysfunction. Just 2 cases published recently in the Lancet Child and Adolescent Health. Next slide. Probably much more much greater problem is that there's obviously an association between people who have experienced COVID-19 and who then develop psychiatric problems or a psychiatric disorder. This is adults, so based on a huge number of people who developed COVID-19, and you can see that in patients with no previous psychiatric history, a diagnosis of COVID-19 was associated with increased incidence of a first psychiatric diagnosis in the following 14 to 90 days, compared with 6 other health events. And you can see the hazard ratios here. So it's quite a substantial increase in the risk to develop a psychiatric disorder after you've had COVID-19. Next slide. This is again showing the increase, the red line showing the increase due to COVID in comparison to, in this case, influenza. So a substantially steeper increase after days after you became ill with COVID. This goes for psychiatric illness in total. It goes for mood disorders, even more so for anxiety disorders. Next slide. It's important to know that this is not readily explained by differences in illness severity. There are clear-cut indications that patients who required inpatient admission are at higher risk of mental disorders than patients not requiring admission. But if you just look at outpatients, there's no clear-cut evidence linking the severity of the COVID symptomatology to your likelihood of developing a psychiatric disorder. And you can see that the diagnosis of a psychiatric disorder in the year before the outbreak actually also entails a substantially increased risk of developing a mental disorder after COVID-19 infection. Next slide. So this is my last slide, and I think I'd just like to point out that there's this so-called fatigue, which is people are unable to work, are unable to really do their daytime chores. They just are able to rest. Basically, they cannot exercise or exercise very little. So it can be a very serious problem, and this is also an issue that may affect children and adolescents. We are aware, I think, at the moment here in our department of 2 patients for whom we have discussed fatigue and major depression and anxiety disorders as a sequelae of a COVID infection dated a few weeks back. And again, there's no association between COVID-19 severity and fatigue following the infection. Females more predisposed than males. And again, those with a pre-existing psychiatric diagnosis are also more frequently affected with such a fatigue. So I will leave it at here, and I hope to have provided you with an overview of the consequences of this epidemic in terms of mental disorders, mental effects on children and adolescents. Thank you.
Herzlichen Dank, lieber Johannes. Also sehr interessant und auch beeindruckend, wie Sie mit verschiedenen Forschungsergebnissen eigentlich auch nochmal deutlich gemacht haben, dass Covid einen gewaltigen Einfluss hat auf die mentale, geistige Gesundheit von Jugendlichen und von Kindern. Ich weiß nicht, ob es schon Fragen gibt. Ich hätte aber eine Eingangsfrage. Diese Entwicklung bedeutet erstmal, dass der Druck auf die psychiatrische, psychologische Versorgung für Jugendliche größer geworden ist und größer ist im Moment. Was müssen wir tun, um das wieder im Griff zu kriegen, um das wieder abzubauen? Welche Maßnahmen wären da wichtig?
In German or in English?
Vielleicht auch mal auf Deutsch, kurz
okay.
Stückchen.
Ja? Ich versuche dann langsam zu sprechen. Also ich bin mit Wouter absolut eins, dass eine Normalisierung das Beste wäre. Und eine Normalisierung kann eigentlich nur, also ich glaube, der wichtigste Baustein dazu ist eine hohe Impfquote. Also ohne Impfen wird das nicht funktionieren und wir werden sonst ja weiterhin Probleme haben. Und Sie alle verfolgen die Diskussion zu dieser neuen Delta-Variante. Und wenn das jetzt im Herbst tatsächlich nochmal die Kinder und Jugendlichen besonders betreffen würde, weil alle anderen geimpft sind und Kinder und Jugendliche noch nicht geimpft sind, dann ist das, glaube ich, ziemlich hart. Zumal dann möglicherweise ja wieder über Schulschließungen gesprochen werden muss. Und in Deutschland passiert das aktuell schon. Also das verunsichert und wäre, glaube ich, für die Gesamtsituation doch eine relative Katastrophe, wenn man diese Daten so sieht, wie sie sind. Ansonsten ist es, glaube ich, wichtig, also in Deutschland gibt es eine Diskussion, eine ungute Diskussion, also auch weil Wouter das Wort in den Mund genommen hat, zu Triage. Es gibt also einzelne Kinder- und Jugendpsychiater, die behaupten, wir machen bereits jetzt schon eine Triage. Das heißt, wir würden uns nur noch um die Patienten kümmern, die also jetzt ganz, ganz, ganz schwer krank sind. Das ist überhaupt nicht so, aber es ist natürlich schon so, dass wir unter verschärften Bedingungen arbeiten und uns einem Ansturm gegenüber sehen, den wir so in der Zeit, in der ich in Essen bin, noch nicht gesehen haben. Und das ist ein bisschen schwierig, dem allem gerecht zu werden. Wir versuchen, also ich habe zum Beispiel selbst jetzt vor ungefähr 3 Monaten begonnen, eine Online-Elterngruppe. Ich glaube, man muss jetzt einfach andere Wege gehen und vielleicht dann auch positive Aspekte der Pandemie nutzen. Also ich hatte keine Ahnung von Online-Psychoedukation bevor Beginn der Psychoedukation. Jetzt mache ich das wöchentlich einmal. eine Elterngruppe zur Anorexia nervosa, weil da sehe ich einfach einen riesen Bedarf. Bin zufällig jetzt auch selber Spezialist für Essstörungen, also von daher tut es mir auch nicht besonders weh und ich kann das einfach so runter aus dem Ärmel schütteln. Aber ich glaube, das wäre ein sehr sinnvolles Vorgehen, dass wir viel mehr versuchen, also Eltern in Gruppen zusammenzufassen und einfach über Internet quasi online versuchen, hier größere Gruppen gleichzeitig zu erreichen, weil wir können das nicht mehr individuell alles managen. Und natürlich ist es auch wichtig, auf kommunaler Ebene, glaube ich, sich gut auszutauschen. Wir haben hier ein sehr schön ein vernetztes System mit Jugendhilfe, mit Schulen, wo wir, also glaube ich, wenn es da ernsthafte Probleme gibt, dann auch schnell im Austausch miteinander sind, um gemeinsam zu überlegen, wie kann man dem Rechnung tragen.
Okay, danke. Gibt es aus dem Chat Fragen?
There are no questions in the chat at the moment.
Okay. Wie kann Jugendhilfe Wartezeiten überbrücken? Weil dat is natuurlijk im Moment een probleem. Dat gilt natürlich auch auf der niederländischen Seite. De Wachttijden, die sind teilweise, glaube ich, ziemlich groß, enorm. Und was ich glaube, sind immer auch sehr kritisch. Lange Wartezeiten sind sehr, sehr schlecht, auch für den weiteren Verlauf, denke ich, auch der Problematik. Welche Möglichkeiten sehen Sie da? Diese Frage könnten, denke ich, von beiden Seiten beantwortet werden.
Also Jugendhilfe ist, in Deutschland arbeiten wir ja relativ getrennt voneinander. Also wir kommen dann schon sehr wohl in Kommunen zusammen, aber es sind zwei unterschiedliche Systeme und das ist ja in Holland eindeutig anders. Also mein Eindruck ist, dass das natürlich auch, also der Vorteil einer Klinik ist einfach, dass wir mit natürlich auch viele Ärzte an Bord haben und die Ärzte einfach dank ihrer Ausbildung irgendwie sich eine Haltung angeeignet haben zu medizinischen Erkrankungen, aber auch zu Infektionen. Das heißt, die wissen einfach so ein bisschen anders damit umzugehen. Ich glaube, die Pandemie hat ja allgemein sehr viel Ängste ausgelöst und Personen, die halt nicht einen medizinischen Hintergrund haben, sind dann unter Umständen haben größere Schwierigkeiten mit den Risiken und mit den Unwägbarkeiten einer solchen Pandemie umzugehen. Und das betrifft dann unter anderem auch die Jugendhilfe natürlich, sodass also da die Schwierigkeiten, glaube ich, deutlich sind. Auch dort haben ja viele zugemacht oder also nur noch für Notfälle zur Verfügung gestanden und so weiter. Also die gleichen Probleme, die wir ja teilweise auch hatten. Ich glaube, Mediziner haben sich da ein bisschen schneller erholt, einfach weil das letztlich medizinisches Kerngeschäft ist. Aber die Auswirkungen sind in der Jugendhilfe natürlich spürbar, ja.
Vielleicht, Wouter, kun jij daar nog iets vanuit Nederlandse optiek aan toevoegen? Microfoon, even.
Bedankt voor de tweede keer. Als ik focus op die wachttijden, wachtlijst, zit daar natuurlijk een... Kijk, waarom dat ontstaat is onder andere omdat de doorstroom daarna niet goed loopt. Dus je kunt bijvoorbeeld zeggen, stel dat we zouden zeggen, we gaan heel veel effort doen om die wachtlijst weg te werken. Dan loopt de hulpverlening vol, omdat je daarna de doorstroming niet op orde hebt. Dus het zijn heel erg communicerende systemen. Wat je zou kunnen doen op het moment dat iemand wel op die lange wachtlijst staat, is natuurlijk die telemetrie gebruiken. Waar professor Hebrand ook al op duidde. Groepstrainingen bieden. Om in ieder geval wat aspecten aan te stippen. Veel interventies gaan bijvoorbeeld heel erg over structuur weer aanbrengen. Hoe doe je dat op een goede manier? Slaap-waakritmes herstellen. Hoe pak je dat aan? Dat zijn hele belangrijke facetten die vaak al gedaan kunnen worden en ook online kunnen.
Mm-hmm.
Maar die wachtlijstproblematiek heeft dus te maken ook met de doorstroom. En daar zit een probleem. Dus dat betekent dat je heel goed functionerende netwerken nodig hebt. waarvan de netwerkpartners van elkaar weten wie is nou het best waarin. Dus het profiel moet ook glashelder zijn. Ik ben bijvoorbeeld niet voor een soort V&D-achtige moloch die dan zegt we doen alles. Maar veel meer in laat nou zien waar je goed in bent en werk dan daarin goed samen. Omdat bijvoorbeeld jeugdzorg bepaalde skills heeft die wij binnen de psychiatrie weer niet hebben. Enzovoorts. En nogmaals, ik zou ook heel erg onderwijs gaan betrekken. Ik denk dat daar een opstuwende kracht soms is vanuit de onderwijskant. Die we niet goed hanteren. En dat zet natuurlijk druk op alle systemen. Maar het is heel algemeen geantwoord.
Ja. Ik zie hier nog een antwoord im Chat. Das in der Schulsozialarbeit überbrücke ich das oft mit Hilfe der Erziehungsberatungsstellen. Also das ist eigentlich auch schon ein bisschen, was Wouter sagt. Zusammenarbeiten mit alle anderen Instanzen, die es da gibt. Und gute Netzwerke sind da sehr wichtig, denke ich.
Ja, und Telemetrie hilft da schon. Das haben wir schon beobachtet.
Ja.
Das kann viel einfacher. Yes.
Okay, also das könnte eine der Errungenschaften sein, auch als Covid, dass man auch anstelle von physischen Treffen da auch im Bereich Umfeld und so weiter über Gruppentherapie, Gruppenarbeit und so weiter einiges tun kann.
Genau.
Okay. Gibt es weitere Fragen aus der Runde?
Ich hatte noch eine Frage für Professor Hildebrand, aber
Mach, ja zeker.
I'll do it in English so that everybody understands. And one of the things of course, we want the schools to be open as soon as possible because that will be necessary for the long-term improvement of mental health. But one of the things we fear is that at the moment of real opening, let's say in the second part of August, that some of our children will not be able to switch to the new situation. And of course, Johannes, you know my interest in autism. I think that group is at high risk. And they will need an extra guidance to go back to school again, I think. But what is your perspective on that?
Yeah, I would totally agree that we're going to have a tremendous increase in school refusal or school avoidance, depending on how you want to call it. And it's not only autism, it's anxiety disorders. It's maybe also externalizing behavior, children who have learned to do something else with their lives than go to school for the last year. But many obviously with depression and are internalizing behavior too, who will have difficulties in coming back to school. I think what we don't know at all anything about at the moment is the effects on cognition. So just, having done nothing for a year, nobody really knows what that does with your brain and what that does when you all of a sudden you again have to show you have to come to school and you have to work. This might be tremendously difficult for a subgroup of, I'm not talking about everybody, obviously, I'm just a small subgroup, but nevertheless, these subgroups add up, and that's the problem. So there's many different subgroups that will potentially have problems, and we'll be seeing many different issues, I think.
Yeah, okay. I always experience it. I lose some IQ points when I come back from vacations.
Okay.
It takes a couple of weeks to normalize again.
Yeah.
Don't take a vacation.
You shouldn't.
I think that is normal because you already mentioned your age and you are not that flexible anymore as the young people. So there is still hope. There's still hope. They are still very flexible and their mind is flexible. So I think there is hope. I would like to thank you, first of all, the audience for the patience having with us, and most of all, Johannes and Wouter for the very, very interesting speech you made. I think we learned a lot, and we can take some of these things back when we think about, especially the people in the municipalities who have the day-to-day work with the problems, that they can take back in their daily practice. So thank you very, very much. And for now, I think I wish you all the best. En ik zou zeggen tot ziens, auf Wiedersehen, bis bald.
Yes.